on, do we have a handheld mic or lavalier mic?
Can you guys hear me all okay? Do I need a mic?
Will we need a mic for the ceiling cameras to record you?
Guys, I'm just going to introduce myself while we're waiting for the mic to get hooked up. I'm Brian Bardini from Baylor College of Medicine. I'm the co-chair of the advisory committee here at Medicine X Ed, and it's been so much fun to watch this evolve. And this is one of the most exciting parts of Medicine X is this rapid sequence presentation panel. So I want to welcome everyone, and it's thrilling because it's kind of fast moving. I went over the sequence just a moment ago with the speakers. We're going to see 3 speakers in a row. Then we'll hold your questions until the end. We'll roll with those then. For the speakers also, 30 seconds before you do, I'll hold my hand up so you see you're coming close on time. Okay? And so with that, our first speaker is Jason Satterfield, who is a professor of behavioral medicine at UCSF, and we're presenting Lost in Translation.
All right, mark, set, go.
Yeah, you can go.
Perfect. Well, welcome everyone and thank you for coming. The 2010s have been called the golden age of medical education. We know a lot more about evidence-based teaching strategies. We know a lot more about what doses of those strategies are necessary. And we also know what are some of the valid, more reliable assessment tools to tell educators whether or not we've effectively done our jobs. And that works pretty well in the classroom. Unfortunately, we haven't done an equally good job when we send our learners out into the communities where they work in community clinics. There is a gap, actually a chasm, between what students learn in the classroom and what they're able to effectively use and continue to learn and elaborate when they're in a clinical setting. We chose to develop a tool to bridge that particular gap in a particular skill set called screening, brief interventions, and referrals to treatment for substance use disorders. Now, the problem that we're talking about here is that the slide looks really funny. All right, anyway, so the problem we're talking about here is one of the most under-recognized and under-diagnosed problems, that of alcohol and drug use disorders. If we count tobacco, it's responsible for approximately 600,000 preventable deaths per year. We know that most of those individuals do see a medical provider, and unfortunately, they're often not asked about substance use or alcohol, so it's an opportunity that tends to be lost. We know that approximately 22 million people need treatment. Only about 11% of those people actually get treatment. And most of the folks with a substance use disorder either don't know they have a disorder or they aren't interested in treatment. So we really have this important opportunity, yet a challenging opportunity for clinicians to really make a difference. And right now it's a lost opportunity. So how do we intervene? So our solution, the evidence-based practice that we picked, was screening, brief interventions, and referrals to treatment. It's been around for about 15 years, so it's not new, it's not particularly innovative, but it's effective and it's efficient. In fact, the Substance Abuse and Mental Health Services Administration has invested literally over $100 million in workforce development to teach learners how to do this in the classroom. Unfortunately, we now have tens of thousands of learners that can do this in the classroom, but they can't do it in the clinic, hence we have the need for this particular tool. So in collaboration with Open Health Network, we created the UCSF SBIRT mobile app. Here's our icon. It is available for free download from the Apple Store and also Android. Now there's 3 important things I want you to know about this app. First of all, it's theory-based. It's based on the theory of planned behavior, so we have an evidence-based idea of what are some of the drivers, what are some of the inhibitors of skill translation from classroom into the clinic. Second, we're using an evidence-based intervention. There's a lot of fancy, really fantastic apps that are out there. Fantastic in the sense that they look good, not fantastic in terms of their clinical efficacy. They simply don't work because they're not evidence-based. And third, when a user logs into this particular app, they're given a series of questions so that we can tailor their experience. Learners come in with different strengths and different weaknesses. We want to tell them what parts of the app would be most fruitful for them to go to so that they can more efficiently and effectively use their time. Now the app has 4 primary functions. I'm going to show you a screenshot for each of those. So first we have review, and this is essentially a reference library. So these are all the things that they've learned in class. Now they have it in their pocket or their lab coat. These are a couple of the submenus, so you can see there's lots of information, lots of categories. Some of it's text, some of it's videos, some of it's visual graphics. The second category is an apply, and this is meant to be a point of care tool. So when you're with the patient, you can take out your tablet, take out your phone. You want to screen for alcohol, you check here, the alcohol screener comes up, it scores it for the student, it interprets it for the student, and it gives them a script of exactly what they can say to the patient, which hopefully they will adapt on their own when necessary. The third is report, and this is really for the preceptors and the supervisors, so this is a sort of audit tool where you can gather information from the learner themselves. You want to know if they're using this, if they need any additional support. And fourth are tools that we've included. We included a social network component so that users could learn from each other's experiences, and we also wanted to do some light gamification because we were concerned about engagement. So here you see that we have a leaderboard. The more points you get, the more lottery tickets you get. At the end of the class, you can be eligible for prizes. But does it work? And the short answer is, we don't know yet because we just finished our study yesterday. So we've only had about 24 hours or so. We have beta tested it, and we did a randomized controlled trial with about 130 learners at 3 different universities, 6 different training programs in the San Francisco Bay Area. So of course we're going to look at engagement. I think that's always going to be a big challenge with any sort of digital tool. We want to see if they used SBIRT more in clinical practice and if that had an impact. Now I think it is important to remember that although we picked SBIRT as our particular skill area, this can be used at just about any kind of medical skill. So now that we have the infrastructure, we're hoping in the future we'll be able to apply this across the board to lots of different issues. So I thank you for your time. I also want to thank the CEO of Open Health Network, who's here, Tatiana Consavelli. And the collaboration has really been one quite fruitful. If you're interested in downloading it, here is the link for Android and also for Apple iOS.
That's great, Jason. Thank you.